Good morning. I think we are live and we can get started. Okay, good morning and welcome everyone. My name is Claudia Aguirre. I am the chair of the Global Esther Alliance for Global Health Partnerships and also work at Esther Germany. And I welcome you all warmly to this joint event between WHO program, Twinning Partnerships for Improvement, and the Esther Alliance. The event is called Improving Health Service Quality Through Health Partnerships, and the focus will be on hospital partnerships and twinning arrangements. We will have partnerships supported by Switzerland, Ireland, FED, and Germany presenting their experience from diverse countries around the world. And the event is available in our YouTube channel. It will be recorded. And if you have any questions, please post them on the chat and we will try to answer them during the presentation. Thank you very much. And I would like to introduce also our moderator for today, David Wickham. He is the representative of Esther Ireland in the Alliance. And he's responsible for the Global Health Program at the Health Service Executive in Ireland. Hello, David.
Hello, Claudia, and hello, everyone. Good morning. I'm delighted to be here, and thank you for inviting me to participate. I think we have a very interesting session ahead, so I'm very pleased that we've been able to put this together. Today, we're going to be putting a spotlight, I think, on two big issues for improving health. The first of these is the imperative to improve quality of healthcare in order to achieve universal health coverage as part of our challenge to achieve the SDGs by 2030. And I think we've realized so much more in recent years just how important quality is, that it's not just enough to improve access of care for people, and that if we're going to achieve universal health coverage of better health, we need to really address the issue of quality. And the other issue we're putting a spotlight on today is that of health partnerships and how health partnerships as an approach can improve quality of health services. And today we're particularly focusing on institutional partnerships. So partnerships between institutions between high and low and middle income countries, and how these partnerships can improve and contribute towards the goal of improving universal quality health services. I think today is very much about sharing practices and experience, and we'll have WHO setting the scene, and then, as Claudia said, we'll hear then from about 5 different partnerships from institutions in Europe, in Africa, in Asia. And these, I think, are really excellent examples of how partnerships in practice are seeking to improve quality. I think one of the really good things about today's session is we've got speakers from both institutions in the partnership. So the institutions in Africa and Asia and the institutions in Europe. So we have a great lineup of speakers. We've 11 speakers in all, so that's a full program. We encourage you to participate and to share your questions. We plan to have 2 times of Q&A, one about halfway through and the other at the end. So please put your questions into through the Q&A. And also, we have many speakers, and I'll be saying, just remind the speakers that we'll be trying to manage the time well, and please excuse me if I jump in if time is running on a bit. We'd really like to have the time for the questions and answers. So we'll move on and to start, and there is no better person to start our event than our keynote speaker, Dr. Shams Syed from WHO. I think for many of you, he needs no introduction at all. Whenever the topics of quality and health partnerships are raised, the first person I always think of is Shams. And Dr. Shams Syed he's the quality team lead within the Department of Integrated Services in the UHC and Life Course Division at WHO headquarters. He directly oversees WHO National Quality Policy and Strategy Initiative, as well as WHO's technical work on quality in fragile, conflict-affected and vulnerable settings. Shams also oversees WHO work on twinning partnerships for improvement and he's led this work in WHO since 2009. And he's also currently coordinating design efforts related to the COVID-19 Health Services Learning Hub at WHO. So Shams, you're very welcome, and I'll hand over to you for your presentation.
Thanks very much, David. That's a very kind introduction, and greetings, everybody. Can I just check, you can see my slides and hear me okay?
Yes, perfectly.
Excellent. Colleagues, in the next 9 or 10 minutes, I just wanted to touch on a few key points related to improving health service quality through health partnerships. So first and importantly, I think it's imperative for us to look back at some of the knowledge and wisdom that has emerged from global examination of quality of care. And many of you will have looked and examined these reports in detail. In 2018, 3 significant reports, one emerging from WHO, the World Bank and OECD, one from the Lancet Global Health Commission, and one from the US National Academies of Science, focusing in on building the evidence and responding to the call for a UHC with quality that David just highlighted. A few key points that emerged from that, and if there was only one piece that we could remember, perhaps this would be it. Ultimately, quality of care is looking at how to prevent mortality and morbidity. The Lancet Commission really emphasized the mortality case for quality of care, estimated 8.6 million deaths per year in 137 low and middle income countries due to inadequate access to quality of care. Importantly, of these 8.6 million, 3.6 million are people who did not access the health system, and 5 million of the 8.6 million who sought care but received poor quality of care. And that's where the pie chart that you can see there, a very simple one, but with profound meaning. Each one of those numbers is a human life. Importantly, it's not just about looking at the burden, but it's also about looking at what we can achieve through high quality health systems. And the numbers there speak for themselves related to the potential for prevention and the potential for saving lives. In the COVID-19 world, we do need a continued and intentional focus on quality, both for care for patients with COVID-19, as well as maintaining essential health services. If the same principle applies, then we recognize that there will be likely an increase in deaths related both to access and quality, and we're not sure which will have the greatest effect. But again, coming to this point about an intentional focus on access and quality. So thinking through quality, just to remind ourselves, and this is directly from the World Bank WHO OECD report, but the domains, effective care. So many of the colleagues on this call will be clinicians focusing in on effective care as a key domain of quality. Safety, hugely important, and many of you would have participated in World Patient Safety Day, really emphasis here on saving lives through ensuring that we provide safe care. People-centeredness, not a soft issue, hugely important, and the issue of compassion has been coming up repeatedly, particularly in the COVID-19 world that we see. And just reminding ourselves of the 4 other domains, which are very important to consider in one whole interdependent way for quality: timeliness, equity, efficiency, and integration. But just reminding ourselves now that while we can talk about those principles, quality is not a given. And in the words of our Director General, it takes vision, it takes planning, investment, compassion, meticulous execution, and rigorous monitoring from the national level to the smallest, remotest clinic. And that's particularly where the work of institutional health partnership comes in. And when we're developing national directions on quality, implementation experience and the work at the front line is so critical, because otherwise a dialogue on policy or strategy or national efforts can be uninformed by the realities that are faced by the front line. And this is where the work of institutional health partnerships can make a huge difference. So our usual focus on policy somehow leading to strategy and somehow leading to implementation can be flipped around, where implementation experience actually informs and drives policymaking and strategic direction setting. And this is where the concept of quality improvement can really come of its own. The action of every person working to implement iterative, measurable changes to make health services more effective, safe, and people-centered, a working definition. Many of you will be familiar with the Twinning Partnerships for Improvement approach, the focus on a strong bidirectional partnership, tangible improvements, real improvements that save lives, and ensuring that those improvements are spread throughout the system. I think today we're going to hear from a range of partnerships that have really focused in on different components of this approach and ensuring that there's a stepwise approach, and the 6-step approach of the Twinning Partnerships for Improvement, I think many of you are familiar with. We'll also hear an example of that being applied from my colleague later on. I did want to make one plea, and some of you will know that this is an area of active exploration for many of us, but the whole concept of innovation and knowing no boundaries, the partnership-based approach provides a huge opportunity to ensure that learning flows in all directions, north to south, south to south, and south to north. It's some stage was a novel concept, now is being seen as a natural part of an institutional health partnership, but we shouldn't forget the power of institutional health partnerships in this space, because in many of the global health dialogues, we still need to persuade people about the huge potential of learning that flows from what we previously had called developing countries to the so-called developed world. This is an area where the institutional health partnership movement and action can have a huge effect. So just reminding ourselves also that within the Sustainable Development Goals, we always emphasize our strong focus on universal health coverage. David had already mentioned this in his framing. Quality is embedded within the definition of universal health coverage. And Sustainable Development Goal number 3 can perhaps be not more important ever than it is now as we rebuild from the COVID world that we are facing. Also, and important to emphasize, the interdependence of all of the SDGs, and many health components exist in multiple Sustainable Development Goals. And the SDG 17 on partnerships for the goals, institutional health partnerships has a huge opportunity to operationalize the principles in SDG 17. So there's a real opportunity for SDG 3 and 17 to drive our work. So just wrapping up here, one important point, just a few of those. We do need to ensure quality is recognized as a fundamental precondition of service delivery and health systems, and keeping at the heart of UHC. It's there, but it needs to be talked about and it needs to be acted upon. We do need to build in quality improvement into the core of institutional health partnerships and build the architecture for change. So partnerships are really focused in on improvement. That's the rationale and the reason for the existence of virtually every partnership, how to improve things at the front line. Ensure the strong linkage between partnership work and national direction setting on quality, so that institutional partnerships are contributing to a wider good, and ensuring the whole principle of co-developing solutions through partnerships with strong links to the global knowledge architecture. So events like this are really important to make sure that the lessons that are being learned are being shared in live time to inform others. With that, I wanted to thank you, and also to remind us all that we often talk about the 17 Sustainable Development Goals, but we sometimes forget the original 5 Ps that the SDGs were built on, and recognizing that the 5th of the 5 is partnerships. So with that, I'll pause And thank you so much for this opportunity. And I'm really looking forward to listening very carefully to all the wisdom of the colleagues today. Over to you, David.
Wow, thank you very much, Shams. I think that's so good. I think you've set the scene really well for today. I think no doubt you've about the importance of quality for health services and highlighting it in COVID times as well. And I think just and for reminding us just how partnerships, the work of partnerships is so embedded in the SDGs. And I really liked your comments about the innovation flow between countries. I think that's a great message for us. But that sets the scene well, I think, for our moving on to our different examples of partnerships. And we're going to now move to Esther, Germany, and to Dr. Kirsten Gross-Free, who will share with us the key achievements of the regional program, University and Hospital Partnerships in Africa. And Kirsten is the advisor of the regional program, University and Hospital Partnerships in Africa at GIZ. She provides technical and organizational support to the partnership projects between German and African university and teaching hospitals. Her focus is on monitoring and evaluation and networking with partners and stakeholders to ensure sustainability and spillover effects of the projects. And after Kirsten, then we'll hear from one of the partnerships under this program, and that's the health partnership between the University Medical Center Hamburg-Eppendorf in Germany and the College of Medicine at the University of Malawi, Blantyre in Malawi. And so I'll also introduce the two speakers who will talk about that. That's first is Dr. Tamara Firi, who's a clinical lecturer in internal medicine at the College of Medicine in the University of Malawi. And since July this year, she's been working as a clinical lead for the Queen Elizabeth Central Hospital COVID-19 inpatient care service. Besides that, she's the deputy head of the internal medicine department at the Malawi Ministry of Health and the president of the Malawi College of Physicians. And she has a vast interest in non-communicable diseases research. And she'll speak together with Dr. Benno Kruls. He's a consultant in tropical medicine at the University Medical Center Hamburg-Eppendorf. And he's currently head of the collaboration between the University of Hamburg and the College of Medicine to improve patient safety by the introduction of point-of-care ultrasound into routine medical care. So I'll hand over to you, Kirsten, and invite you to make your presentation.
Thank you very much, David, for the kind introduction. I will first share my. Can you see it?
Yes, we can see it, yes.
Okay, and thank you, Shane, for setting the frame for this webinar today. I'm presenting the regional program University and Hospital Partnerships in Africa as part of ESTER Germany. And I want to show you the results of our former funding round on patient safety. During that phase, we supported 15 partnership projects in 12 countries in sub-Saharan Africa, mainly between university and referral hospitals in Germany and Africa. Each project received 150,000 euros, and overall we spent 1 million euros between 2017 and 2019 for all partnership projects. We implemented the projects as a program from GIZ on behalf of the Federal Ministry for Economic Cooperation and Development. 15 German and 27 African institutions participated in the partnership projects. We supported different activities, and main activities that were implemented by the partnership projects were training, guideline development, networking workshops, procurement of equipment, and joint operational research. At the end of 2019, we received the final reports of the partnership projects. From this, we know that at least 1,843 African healthcare workers were trained, such as doctors, midwives, nurses, and lab specialists. 56% of these were women. Also, 9 articles were published by our project partners in scientific journals, and 41 scientific presentations of the project results were held. A network was founded during this project phase on antimicrobial resistance, and it was composed of 6 African and 5 German university hospitals. The network still exists and is also funded in our current round on e-health. An online course was also developed in cooperation with the University of Heidelberg on patient safety in clinical and resource-poor settings. This module also still exists and is used by the University of Heidelberg. Some projects also reported impressive data on how they improved the quality of care. For example, the partnership project between Guinea and the Robert Koch Institute reported an increase of hand hygiene among the hospital staff of 70% after implementing WHO hand hygiene strategies. Another project between Sierra Leone and the Charité Berlin reported a decrease of 20% of maternal mortality and an increase of about 25% of facility-based deliveries. The project between the University Düsseldorf and the Asella University in Ethiopia reported a decrease of 30% of hospital-associated infections after implementing hygiene activities. Another very successful project is the project between Malawi and the University of Hamburg. I'm very happy that Tamara and Benno are here today to present their partnership and give you a much deeper insight in how such a partnership works, and to present you their activities and the impact they had on quality improvement. I also want to thank all other partnership projects that helped to achieve these results of this funding round. I also want to thank you for your attention, and my team in Frankfurt for the support. Thank you. And with this, I would like to hand over to Benno and Tamara to present their partnership.
Sorry, Benno, we can't hear you. You're on mute.
Yes, sorry. I'm in the hospital. It's quite loud here, so I have to keep it on mute. I'm trying to share my screen for Tamara to start the presentation. I was just saying thank you for the invitation. I assume you can see my screen now?
Yes, we can.
Yeah. And if I start the presentation, okay. Can you see this presentation in full?
Yes.
Yes.
Okay. So Tamara, you wanted to go ahead.
Sure. Thank you, and thank you for the invitation to this meeting. My name is Tamara Piri. I am a physician. I'm based in Blantyre in Malawi. I work for the College of Medicine under the University of Malawi. And today I'm going to be sharing together with Benno on a project that we're currently working on together between the College of Medicine and the Hamburg University. So we are currently running a project on point of care ultrasound. And I'm just going to explain briefly what that is. So essentially, point of care ultrasound is ultrasound that can be done on a patient for clinical evaluation wherever the patient is. So this could be a patient that's in the ambulance, a patient that's in the ward, or a patient that's in the emergency unit. You can do ultrasound on them in any of those places. And the main use of this is it answers a specific question which helps you with the clinical management or decision making for that particular patient. And also a key thing about point of care ultrasound is it's very easy to learn, it's very easy to perform, And also there are particular, very recognizable findings that people are trained to look out for. So I just want to emphasize at this point what POCUS is not. So it's very different from a thorough radiological assessment, which a specialized radiographer can do. So it's not a comprehensive study, and it's also not specifically performed by radiologists or radiographers. So we can train any of our doctors to do this. And it's also main use is limited in the hospital or at the bedside. So you can actually do it anywhere. So just to give you an example of the sort of questions we can answer with POCUS. So firstly is looking for fluid in spaces in the body. So if you're looking for free fluid in the pleura or peritoneum or pericardium, you can easily answer that with POCUS. And also in addition to that, you can assess the basic heart function at the bedside. And also you can look if a patient has got a pneumothorax. So for example, a patient that comes in acutely short of breath, you can easily make that decision with POCUS and decide whether this patient has a pneumothorax or not. So right there at the bottom, you can see the first picture on your left. That's an example of a pericardial effusion, which you can see with POCUS. And on your right is an example of splenic microabscesses, which you can see in a spleen in a patient with disseminated TB, which is something that we commonly see here. So how exactly does POCUS improve the safety and quality of care? And this is particularly important in a setting like Malawi, where we have a huge patient load and very few radiologists who can actually scan them. So firstly, it makes imaging widely available because anyone who's trained to do this can do it at any time without waiting for particular bookings. And it also shortens the time that we wait between diagnosing a patient with a particular condition and starting the management, because we can get answers there and then. And then also, thirdly, and most importantly, is it shortens the duration of stay because we make decisions quicker and we can act on particular conditions very quickly. And it also reduces the rate of complications during procedures, especially the clinical procedures that used to be performed blindly. They become much safer once you can see what exactly you're doing with POCUS. So these images just show you the previous courses and trainings that we've done. So the training has got a classroom component where we have trainers, and we've had trainers that have come in from Germany, and also we are now having local trainers that will take the participants through the training. And then a big component of the training is hands-on sessions. So the people that are being trained will go into the ward and they will do scans on our patients as part of our clinical management. So this just helps you appreciate what this looks like. And just a brief history of this partnership. So this idea actually started early in 2017. It was an idea that came up during the ward rounds in Malawi, when Benno was in Malawi. And then a few months later, that's when the partnership was actually implemented. And then 5 months after that, a needs assessment was conducted and a curriculum was developed. And then after that, in March of 2018, that is when the first training course was done. And by February of this year, we have trained 58 clinicians as POCUS users. And we have 12 of these who've been trained as trainers, so they can train others in another POCUS course. And 4 of them have been trained as lecturers. So it's been quite successful so far.
Okay, thank you for that bit, Tamara. I will take over from now, and I'd like to show you a bit of data that we collected in the hospital after we had implemented the scan. That data here was collected at the end of 2018 after we had conducted 2 courses in the hospital. In this study, we screened 835 patients over a time period of a few months to look for whether they had ultrasound examinations conducted, because we wanted to find out of the ultrasound examinations that are being done, what are the indications that they're being done for, and also how many of them are actually being conducted as POCUS after we had implemented the training. And what you can see in this table is the 267 ultrasound examinations that we looked at. A large proportion of them were abdominal ultrasounds, echocardiograms, and FASH. FASH is a protocol that covers free fluid, lymph nodes, and splenic microabscesses, and is a very standardized way to look for disseminated TB and HIV patients. And as you can see, those are the main indications that ultrasound is used for. And for these indications, you can see that 30% approximately of the ultrasounds are conducted as POCUS for abdominal scans and echocardiograms, but 90% of the FASH scans are performed by the clinicians. And when we go on to look at what influence these ultrasound examinations had on treatment, this is a small section of a very big table, but I think this bit I picked out because it demonstrates that if we look at the scans that were performed, abdominal scans, about 50% of them either led to a treatment being started or treatment being altered. And that is particularly for FASH scans or echoes. Admittedly, the numbers are quite small, but still that 60% of the echoes led to treatment being started or treatment being altered. And the same thing for FASH is starting TB treatment early and starting treatment of heart failure early can make a huge difference for the patients. And if we look at how long it took to get the scans, this graph shows you that more than 60% of the POCUS scans were conducted on the day that the patient was seen the first time, whereas the median time of the radiological ultrasound, which means you have to send in a request to the radiology department, you have to wait for the patient to go there to get the scan, was 2 days. So we've shortened the time to the first scan by 2 days. And you can also see there is a tail end, but at the time we collected this data, not everyone in the department was trained. So I'm quite sure when we repeat this examination, this study again this year or early next year, then we'll see an even bigger proportion of the scans being done early. A partnership is always about benefits for both sides. And I have to say, for me personally, the huge benefit is that we have new collaborative research opportunities and also training opportunities, not only that we can conduct research, but it's also, I spent 2 years working at the college in Malawi. I think my capacity was built a lot by the college during my stay there. And I've had several requests from clinicians in Germany who are actually looking for training opportunities in Malawi. So I'm quite sure that we are benefiting massively from this partnership on the German side. And for the Malawi side, Tamara would like to take over again.
So for the Malawi side, I think we've seen key benefits in continuous education and staff development, which has been built on into the POCUS course. And this has been continuous. And we can actually see a difference in the way our staff members are learning and how they're using POCUS in their day-to-day work. And also in addition to that, it's greatly improved our quality of care, and this, you can see that in how quickly we can now make decisions and act on patients. And also there's been a reduced length of stay. As you saw on Beno's data, we got results back quite early. And also something that has happened after this POCUS course is it's got very good buy-in. It started in the Department of Medicine, but we're now rolling it out to other departments, and it's applicable to anesthesia and obstetrics and surgery. So there's been quite a lot of interest for us to keep on growing this and then see how we can extend it to other departments and hopefully other places in Malawi as well.
Yes, I think the current status of the partnership, and especially the future perspectives, is we've created sustainable improvement in quality of care. We are no longer flying in trainers only from Germany to do the training. We have Malawian clinicians, and this is not only doctors, it's also clinical officers trained in a way that they can conduct the hands-on training and also that they can present the lectures at the College of Medicine during the trainings. At the same time, the curriculum review for the postgraduate training in medicine has included POCUS as a mandatory part of the training to be delivered to everyone training in internal medicine. Tamara already mentioned that it's becoming very interdisciplinary. So we have buy-in from a lot of departments now. We're extending the courses to obstetrics, for maternal health. We're extending to pediatrics. We're extending to family medicine, which is not only based in Blantyre, but is based in different parts of the country as well. So that we're scaling it up in trying to drive it from the central hospital into the districts. This scale up and decentralization is also being put forward now by creating an app in the new e-health program phase, where we are creating an app to contain the content to actually enable people to sit and do the learning, the theoretical bit themselves at home, and then get the practical trainers to do the hands-on training without having to deliver the lectures in short courses. We're in touch with GIZ in Malawi with the health program there. We have contacts to Worldwide Radiology, which is an NGO that's based in the UK. We have contacts to an American NGO that is scaling up training midwives in point-of-care ultrasound in Malawi. We have collaborations in Uganda, Gabon, and Nigeria, where we're working on research projects in sepsis, in Lassa disease, in cardiology, to evaluate the use of point-of-care ultrasound in these subjects.
So if I could ask you to finish up in a minute, Ben.
Thank you again.
Exactly. Your time is running out.
1 minute over. If you have any questions that you don't want to have put into the chat, or are interested in collaborations, which we are very interested in, here are our email addresses.
Great. Well, thank you very much. That was really interesting. Very good insights into the workings of the partnership, how you can improve quality of care, how the partnership has benefited the partners. So that's very informative. We keep moving now onto the next presentation. And just if you have any questions on that, if you just please put them in the Q&A box, and we'll hopefully come back to them. So thank you very much, Tamara and Benno and Kristen for your presentations. So we'll move on now to the UK and the King's Global Health Partnerships to hear their experiences in using quality improvement approaches in partnerships between the UK National Health Service, King's College London, and partners in Zambia. And I'd like to welcome the two speakers here. Firstly, Dr. Misa Funyika Mulamba, who's a medical doctor working for the Ministry of Health in Zambia, based at Ndola Teaching Hospital. She's an ophthalmologist and the head of clinical care at the hospital, and she chairs its Quality Improvement Committee. And she'll present along with Laura Semple, who is NHS Engagement Lead at King's Global Health Partnerships, a role that she created. And Laura was the first healthcare manager to volunteer full-time with the King's Sierra Leone Partnership in Freetown in 2016. She also led a major program on hospital leadership capacity building across the 4 King's global partner countries of Sierra Leone, Somaliland, Zambia, and DR Congo. So I'd like to hand over to you, Misa and Laura, if I could, for you to do your presentation. Thank you.
Thank you very much for the introduction, David. Can I just check everyone can hear me and see the slides okay?
Yes, indeed, yes.
Okay,
Very good.
excellent. Thank you so much for the opportunity to speak with you all today. I think this is a fantastic programme, and Misa and I are very much looking forward to sharing our experiences in learning. I've already learned a huge amount already this morning, so looking forward to continuing. So without further ado, I want to start by just sharing an overview of where we work. So we are 4 partnerships with Sierra Leone, Congo, Zambia and Somaliland, and we're a collaboration with 4 National Health Service hospitals, 3 hospitals and 1 university, King's College London, over in South London. And we've had a real focus on hospital management and leadership for some time now, as David said in the introduction, because we absolutely recognise the central role that hospital management and leadership plays in improving the quality of care. And as you can see, we have 4 areas of focus within this. It's a vast area. We decided we needed to be quite focused in our approach. Quality improvement is right up there at the top, and that will be our focus for today. We also have a strong interest in patient record systems as a key enabler, which I'm going to speak about in a moment. We also have a strong interest in human resources and strategic planning. So those are our guiding areas of focus. And today, for reasons of time, we've decided to focus primarily on our Sierra Leone partnership and our Zambia partnership. We have many other examples from the other places that we work, and we'd be delighted to have follow-up conversations with colleagues with an interest in DR Congo and Somaliland. So the way we're going to do this is I'm going to start with a couple of examples of work from our Sierra Leone, and then pass on to Misa to talk about her sterling work with colleagues in Zambia. And then at the end, we're going to share with you some of our overall learning points from the work so far. So let's take a virtual trip to Freetown. And as David mentioned in the introduction, I was the first non-clinical volunteer to spend a considerable amount of time with the partnership towards the end of 2016. I'd always had an interest in global work, and my background is in operational management of National Health Service hospital care in the UK. And I was really delighted to have this opportunity to work with the team in Freetown. From my NHS work, I've got some considerable experience in designing effective patient record systems. And I wanted to start with this wonderful equation, which you see on the right of the slide, which I've taken from David Ansel, who's a physician in the US, and he says narrative plus data plus action equals change. We really need all 3 components to do something meaningful. And with that in mind, we had a real focus on records and data capture in Sierra Leone. It wasn't possible for us to design an IT driven system, so we set about working together with the health records team in the hospital, who you see there in the picture, to put in place a very simple but highly functional paper record system, which we were really proud to deliver within 6 months. And I was back in Sierra Leone briefly last year, and it was incredibly rewarding to see that not only has the system that we worked on together very much sustained, it's also continued to be refined and further developed by colleagues, which is incredibly gratifying to see. I was personally very proud of the work we did to develop a context appropriate and reproducible patient unique identifier. This was not easy, and it took many cycles of improvement to come up with something that worked. But we're particularly proud of that and happy to share that with anyone who's interested. Crucially, as everyone here knows, good quality data capture is absolutely essential for QI and for that iterative learning and change process. And the most rewarding thing of all, I think, about this work is that we've now seen a huge range of clinicians start to use the records for really robust quality improvement projects and indeed research projects working with the university. And this is really exciting to see. And Looking ahead to the future, I think the future is bright. Quality improvement is a priority area for the Sierra Leone Ministry of Health and Sanitation, and our partnership will continue to support. Moving on to a second example from Sierra Leone, we have an interest in the management of fever. Around a third of patients present with fever. So I don't need to explain to anyone here today the really high impact that work on pathways relating to this can have. As we don't have much time today, I just wanted to present you this overview of our theory of change, showing the really robust and multi-layered approach we've taken to this. We started this programme with a really detailed process of process mapping, where we looked at the pathway from the patient's point of view and discovered that it could take up to 35 steps for a patient to get a malaria rapid diagnostic test. And through the project, we've been able to reduce that number of steps to just 3, which we're very pleased with and I think is really good progress. What I also want to emphasise about this project is, as other speakers have said, the importance of multidisciplinary working. We've involved colleagues from the lab and the pharmacy and put in place some highly practical process improvements to really make a difference, improve quality of care and reduce mortality for people with suspected or confirmed malaria. And we look forward to seeing that cross-hospital work continue to thrive in the future. So without further ado now, I'm going to hand over to Misa in Ndola to talk about some of the wonderful work that the QI committee under her leadership and that of colleagues has been doing over the past 5 or 6 years since the committee started. So over to you, Misa.
Thank you so much, Laura. So I'll probably give a brief background. Ndola Teaching Hospital is the second largest tertiary hospital in Zambia. We're based on the Copperbelt province of Zambia, and it was opened in 1972. So we see an average of 500 outpatients every day. Our relationship with King's Global Health Partnership focuses on 4 key areas: infection prevention, strengthening of the medical unit, research, as well as quality improvement. So our quality improvement committee is committed to strengthening and the care that we give to our patients. So the quality improvement committee usually meets once every month, and it's a multidisciplinary type of quality improvement committee. We have the clinicians, we have the administrative officers, we have nutritionists, social workers, the engineers, as well as the pharmacy department. So when we sit in these meetings, we're able to see the gaps that are there when attending to patients and address them as a team. So our partnership with King's Global Health Partnership has resulted in reciprocal visits where we visited the UK to just appreciate how the QI committees work there, and they came to appreciate how our QI committees work back here in Zambia. So the purpose of these committees in brief is to ensure that the provision of quality health care to patients meets the standard that have been set by the Ministry of Health. And we also aim to identify gaps between the required standards and the services that we are providing, as well as design and implement interventions to cover the gaps that we've identified. So an example of a quality improvement project that we've come up with is one aimed at improving neonatal and maternal outcomes at Ndola Teaching Hospital. So basically from this QI project, the objectives were to reduce stillbirth and neonatal deaths by 50% by next year, 2021, as well as reduce maternal deaths by 50% in 2021. So among the gaps that we came up in the QI committee was that neonatal sepsis and beta asphyxia were the leading causes of neonatal death. And then we also noted that there was a gap in skills among clinicians when we compared the skills from the consultants, the skills to the junior officers, as well as the midwives. We noted a gap, and also early diagnosis and management of some common conditions like hypertensive disease was also found to be a gap. So some of the interventions that we came up with was that we organized a workshop in partnership with our partners where we called the clinicians, the nurses, to just bring them on board, see how they can identify the gaps in the department and come up with ways in which we can sort out challenges. We also focused on the use of the pathogram so that we improve monitoring of the mothers that come in labor, and hence notice or clinical staff and random checks in individual practices, as well as ensuring that most of our midwives are trained in emergency management of obstetric complications. So these are some of the gaps and interventions that we came up with to try and address the issue of maternal death and neonatal death.
Thank you very much, Misa. So this is our final slide, and we're really interested in exchanging learning with colleagues. And I wanted to include these two photographs, which show some of our colleagues in Sierra Leone quite recently working on the oxygen supply in the hospital there. And I think for me, this is just a very nice metaphor about, in the pictures, about making sure everything's joined up and connected. So on that point, we include here in I guess some of our top learning is about the interdisciplinary involvement in this work. So we've created a hospital management advisory group based in London, encompassing advice from a wide range of relevant disciplines, including QI specialists locally. No single person has all of the advice that we need, so it's a very broad group. At the same time as encompassing that broad range of advice, we have very much recognised the need to be very specific. You know, there is so much to do, there is so much we could do, but we can't boil the ocean, and so we have to be focused. And I think that the examples we've presented today are good examples of that. Because, as we say further down the slide, quick wins are important for creating momentum and giving people the belief that they can achieve things when they use QI methods. And I think the medical records work we did in Sierra Leone was a good example of that. People gained a lot of enthusiasm and confidence from seeing what can be done where a specific area is giving focus for a good amount of time. And I think all the projects we've talked about today also emphasise the importance of on-the-ground support for implementation. And we did also on that point wanted to emphasise the mutual benefits for volunteers from the UK, as well as our partners in the country we work with. I've certainly taken a huge amount of the learning that I had in Sierra Leone forward into my work in the National Health Service since. I'm going to hand back to Misa to share a couple of final reflections.
Thank you. Continuing with what we've learned so far, we've learned that health system strengthening, I think will go a long way in improving patient care, that we need to develop a good process map of how we are going to attend to the patient from the time they come in up to the time they leave the hospital. Also, real change happens in real work. And it's important that the frontline workers, the people that work in the hospital, own the changes and own the things that we are developing, so that together we're able to work together and make change happen in a positive direction. And last but not the least, we've noticed that behavior change takes time. Behavior change can only be achieved in small steps. Like we need to take one step at a time. As Laura put it, small steps. That is how behavior change can occur. Over to you, Laura.
Thank you very much, Misa. And yes, so much of the work that we're talking about today is helping colleagues to learn, change and develop their practice and behaviour. And I particularly like this phrase that I learned from our friends in Sierra Leone, that this change is small, which means that it takes place gradually. We have to stick at it, we have to persist, and we have to keep working together to see the change that we seek. That's it from us for today. Here are my contact details. Really happy to follow up with colleagues afterwards.
Thank you very much, Laura and Misa. That was another very interesting presentation, another very, very nice insights into the workings of a partnership and some of what we can learn from this. So I think this is great learning for all of us. I think to hear some of these experiences that I think we can think of in other contexts. So we're doing quite well in time. We're just a few minutes over, but we do have a little bit of time now for some questions. And I'd like if all of the speakers so far could just put on their cameras again, and if anybody wants to add anything into the Q&A. But one question that's come up that I think is relevant and might be of interest to hear from you, and that is from Atif El Maghrabi, has made a point that the partnerships are important and strategic in managing change and continuous quality improvement, but it's a question about the scale and the budget allocated, both in the short and long term, to have an impact. And I think this is a pertinent question where we've heard about some of the cost of the work, the projects that some of these partnerships undertake. And in low resource settings, how realistic and feasible is it to be able to spread these initiatives? And it might be just be very good to hear people's perspective on that, on the cost and how to have an impact in low resource settings. Perhaps Sham, might I just ask you first for a comment on that, and maybe if some of the others want to come in after that.
Yeah, thanks for that, David, and thanks for the question to Atif. It's an important one, and this answer probably is going to be a little bit unsatisfactory. My inclination when asked about resources and sustainability is to emphasize that clear scoping around a specific partnership with specific outcomes, deliverables, and improvements is already saving lives, right? So there is an added value in that partnership, and particularly partnerships that are sustained over a long period of time. And when those partnerships are plugged in to the national strategic direction on the quality of health services that a country is deciding upon itself, then there can be a huge synergy. There's the potential of synergy, and allowing that strategic direction to be implemented in some ways through the power of institutional health partnerships. And what institutional health partnerships allow folks to do is to get really granular in real examples of change. The sorts of changes that we've just heard from all of the speakers, going right down to the point of care. That would be my initial thought, and particularly as countries are rolling out their strategic direction, there can be nothing more valuable or important than changes at the point of care. And the examples that we've heard just now are exactly those types of examples where there's a real drill down to clinical care, and that is then informing national strategic direction. I know, for example, in Malawi, there is a clear direction on the quality of health services, and the types of experiences that we've just heard from the partnership with Hamburg are the types of things that could really inform that strategic direction. Thanks, David.
Great, thanks very much, Shams. Would anybody else like to respond to that question? Yes, Laura, please.
Yeah, thank you. So, I mean, speaking from our experience in King's Global Health Partnerships, it's been very important to us from the very beginning, 20 years ago, when we started working in Somaliland, to engage at multiple levels. So we engage in our partnerships at policy level with ministries of health, as well as at institutional level with hospitals, and also with universities, medical, nursing, pharmacy schools. And I think we've really experienced the power that working at those multiple levels can bring, because the partnership itself can help to, if you like, be the glue between those levels. And I think, as Shams was saying, where we see clinicians at the front line, you know, and non-clinicians working at the front line, really get confident in quality improvement and build, you know, a really strong, vibrant atmosphere around it, then that also helps with the engagement of policymakers. And I mentioned in our talk that quality improvement is a priority area for the Sierra Leone Ministry of Health, and I think that's a good example of that. So I think we've seen in the partnerships how colleagues working in different areas can grow together and collaborate differently together, both within the partnership work, but also we see lots of great effects beyond the immediate partnership at that strategic level as well as the frontline level.
Great. Thanks, Laura. And maybe, I don't know if Tamara or Benno from your partnership, I mean, you made some very nice points about the spread of the work of the partnership to other wards in the hospital, to other hospitals, and so, you know, so building on what you did. Do you have any Any comments on that and linking that with the question of cost, the cost of scaling up the work through these partnerships?
Tamara, do you want to say anything?
Yes. So I think one of the practical elements on the cost is a lot of this work uses people that are already on the ground as much as possible, and the skills are transferred to people who are on the ground, who continue what they've learned even when the German trainers have gone away, and they can become leaders and become a self-sustaining project. But also it's when the other local Malawian facilities see this being done very well in the local context, they also can learn and see how to implement that in their facilities. So I think one thing that sort of takes out the continuous cost of continually training people is you make it self-sustainable by having the locals own it and also continue to run the project.
Okay, thank you, Tamara. Okay, well, maybe we might just finish the discussion at this point, because I'm very conscious of not wanting to fall behind on time, and we will have more time. We can follow on this discussion, the second Q&A, then towards the end. But thank you very much to all the speakers so far. But if we move on then to our next speakers, and we're going to move now to Esther Switzerland. And since 2016, Esther Switzerland has financed 29 partnerships in 19 countries. And its mission, as outlined in its new strategy, is to contribute to health system strengthening and improve population health through the promotion and support of long-term, equal, reciprocal, and mutually beneficial partnerships between health institutions in Switzerland and in low and middle income countries. Esther Switzerland has two funding streams, one for existing partnerships with the maximum of 100 Swiss francs for one new partnership, and a so-called startup fund to explore new possibilities of partnership, or so new possibilities of collaboration. And we're going to hear from the partnership between Ranas in Switzerland and Gonashastaya Kendra, which is the People's Health Center in Bangladesh, which received a startup grant in 2020. And they're going to share about their lessons and challenges encountered by the startup partnership in terms of data collection within the area of behavior change for water, sanitation and hygiene, WASH. So I'll introduce the two speakers. Dr. Ahmed Manzoor Kadir Ahmed is the chief of Gonashastaya Kendra and its primary to tertiary level healthcare programs. He's an experienced physician with expertise in community-based hospital and public health intervention, operation and management in different environments and emergency crisis. And he also oversees the WASH programs in GK's healthcare facilities and other institutions. And he will speak with Dr. Sylvie Kramer from Rana Limited Switzerland, who's an expert in behavior change and has managed various humanitarian aid and international collaboration projects since 2006. And her main fields of work are behavior change, evaluation, monitoring, participation, and environmental education. So thanks, Ahmed and Sylvie, and I'll hand over to you now, if I can.
Thank you very much for the introductions. We will be presenting on this startup partnership between Switzerland and Bangladesh. Like it was introduced, we're going to talk about our initial efforts in data collection for hopefully the program that will include behavior change and capacity building. And I will actually leave the word to Dr. Kadir. Dr. Kadir, do you want to share your own presentation or do you want me to share your slides for you?
You please share the slides. If necessary, I will answer the questions.
Yes, no problem.
That will be better. Okay, thank you.
Okay, whenever you're ready, please go ahead with your part.
So this is Dr. Ahmed Manzoor Kadir from Gonashastaya Kendra. a private organization, health organization from Bangladesh, established in 1972. It is means the People's Health Center, Ganashastha Kendra. Okay, next slide, please. And it just started in 1972 after the liberation war of Bangladesh. It is almost 30 kilometers away from the Dhaka city. It started with the health of the poor people to improve the healthy status of the locality with some mobile clinics and mobile vans at that time. At that time, there is no road communication from Dhaka city to this area where we are residing now. It is a very remote area at that time, but now it is very urban area where we are serving. Okay, we are operating the community-based health approach with the referral support by the referral hospital. Our base program is the community-based healthcare services in our to-reach area all over Bangladesh, and it is supported by the referral hospital, 6 referral hospital in different district, 1 in Dhaka city and one in our main campus. It is in Sabhar. Next, please. Okay, and you have seen here that some of the primary healthcare centers have shown here in different part. We are operating 43 primary healthcare center where we have the facilities for paramedic, doctors, nurses, and all other basic facilities there. And at the same time, we are also operating services for the Rohingya refugee camp in Cox's Bazar. We are running, right now we are running 15 camps in Rohingya area, and we are one of the biggest health service provider after the government in this area. And you have seen here how we are operating this. And this is the whole geographical map of Bangladesh, where we based. It has been written here. You have seen that we are almost in different part in the shoreland, in the river edge, or in the coastal belt, in the hills, and all over the area. It is the Ganashastha Kendra has expanded, not just to expand in every area, but we expand there where there is need of health service for the poor people in all over this. And here I mentioned some of the things, and these are some of the activities by Ganashastha Kendra: health awareness education, wash arsenic mitigation program. We are also doing the mobile medical camp from the medical college in remote centers of Ganashastha Kendra. We are running a health insurance policy, a co-payment policy for the poor people, so that people can have a better access and affordability for the health service. Supported by one pharmaceutical laboratory established in 1980 to supply the medicine in a cheaper price. And disaster management is also one of our core program from the very beginning of Ganashastha Kendra. And other program, there is a agriculture development program. And we have also included the different infectious disease control program in collaboration with the government, and care for one of our big program is the care for the elderly people in the hard to reach area by our paramedic, our physiotherapist, and by our referral centers for the elderly care. And we are also established in a university. It's 20 departments under 5 faculties. Health and medicine sciences is also there. We are running medical college, a dental college, physiotherapy department, microbiology, and other paraprofessional diplomas in our institution. And you have seen here a picture of our university, one of the biggest private universities in Bangladesh. And we are telling it is community-based education, both for the medical student and both for the university graduate. We are telling it a community-based education, because most of our medical students, they need to go to the villages in 4 times during their student life to serve the village people in the remote area. This is one of the unique example in Bangladesh, only in our medical college, so that the student can be a community-based oriented medical doctor in future, because usually the doctor don't want to stay in the rural area. So we want to create them a better community-based doctor from the very beginning of their student life. So this is we call community-based medical education. Next. And during this COVID, we have especially with this some important health and hygiene measures we have taken in all of our health facilities to mitigate the COVID-19, the hand washing corner, then all other safety measures for the our service providers, for the people who are coming to our hospitals, and for the community people. We have established a plenty of hand washing corner in different communities in all of our health centers, and we have really included or engaged many volunteers to award the people during the corona pandemic for their hand washing and other safety measures, wearing masks and others. This is a unique activities, and this you have seen here some of the measures what we have taken, and also continuing still the whole time continuing for to mitigate the COVID infection. So in our hospitals, we are treating both other patient and COVID patient with all proper measures, sanitary and sanitation hygiene preparation. So there is not any outbreak among our staff. We didn't find the corona infection still now, with the greater grace of Almighty. And it is all of our hospital in whole Bangladesh, we didn't close for any single moment. We always open for the treatment of the patient. Where there is many private hospital and other hospital has been they stop their services, but Ganashwasthya Kendra Hospital never stop till to date. So rather the patient is increasing in our hospital. So these are some of the staff oriented program about COVID-19 care, how to behave with the patient, how to wear the sanitation measures, how to use the PPE materials with some pictures. And we also donated plenty of PPE materials, gloves and others to different government health complex, other private health complex. This is one of the picture where we are donating plenty of PPE and other hygiene material to the government staff with support from our development partner. And all this orientation has been gone in all the areas of GK clinics in all over Bangladesh, so that people we can and this is also during the COVID pandemic. This is a system how we are treating the patient here in the left, and also Ganashwasthya Kendra with his own resources and resources from other development partner. We supported almost 30,000 family. We supported with food support during from April to July, and still we are continuing with this. Those it is not directly related to the health, but it is also improving their health. We supported with food support for the day laborers and other marginalized workers who didn't have work during that time. And this is with this, especially with the Ranas project, that we are in our hospital. We are maintaining, of course, some of the health and hygiene and wash measures, but with this partnership, we have really started it in a systematic way, how we can improve these measures in our hospital. That the key problematic areas you have seen that there is infection risk, more infection rate was there. Wash management and infection control prevention protocol was not systematically developed in all our clinics and hospital. No protocol managing wash and IPC behavior. None of the GK received any professional training before wash IPC management and including monitoring system. And from this partnership project, we, though it is a very short partnership project, and due to Corona pandemic, we didn't able to cover all the training and all other measures. But even that, we create a sustainable change and measurable improvement in the mentioned problematic areas and overall to quality of healthcare. And I'm sorry, I'm really infected by being a doctor. To serve the people in the hospital, I have been infected by corona in last 18 November. Still, I am at home under treatment and gradually getting better and coming back from the corona infection. So I'm sorry for that. Maybe I cannot speak properly because I am a little difficult breathing also. Sorry. Thank you. Thank you for listening me.
Thank you so much, Dr. Kadir, for participating in spite of your COVID infection. And I just want to supplement a few points from our side of the partnership. And as you all well know, is that the background of this idea of why to look at behavior change in this context is that the hygiene circumstances, and especially also the hygiene behaviors that we show, all of us, the staff, the patients, the companies of the patients, can prevent contagion and infection, or it can worsen it. And this is where we started doing this startup project with the idea of first doing data collection about WASH and about ICP, so infection control and prevention, in hospitals. And we did so through focus group discussions. We did observations and also interviews with patients, with healthcare staff, and with the companions of the patients, because it seems to be very common for people to come into the hospital with the patients and take care of them. So we looked at a wide range of behaviors and areas. We looked at hand washing, at the personal protection equipment, of cleaning and disinfection, of the cleanliness of the facilities, of the cleanliness of the equipment, availability of resources, their functionality of the infrastructure as well. What kind of water is available for drinking? Is there any kind of treatment? What's the sanitation situation? And we also looked into waste disposal and management. And
sorry to interrupt, Sylvie. Would you be able to finish up soonish?
Yes. Sorry. So we did the data collection tool development. We did the training and the data collection itself. We're currently analyzing the collected data. And what's really interesting for the next step is we do have expert partners for infection control and prevention and for WASH in hospitals. And we're preparing the program application, and the objectives would be to conjointly with local staff develop the WASH and ICP behavior change interventions and the protocols that Dr. Kadir was talking about, and then to use the great potential that JK has to disseminate the interventions, the educational materials that we're going to come up with. And so I'm not going to present ourselves. We are behavior change consultants, and this is why we bring our expertise to the background in behavior change and our approach, which has shown to be effective for behavior change. And the benefits, so this is the last slide, that we also expect is to learn about ICP and WASH behavior change in hospitals specifically, and to create an adapted approach with the local support, which can then be used internationally as a methodology to disseminate to similar hospitals, or to create that same sort of system with them. Thank you.
Thank you very much, Sylvie and Dr. Kadir. Sorry you were pushed to the end. I know you have so much to say, but unfortunately we do need to watch the time. And Dr. Kadir, particular thanks to you. Very sorry to hear you've not been well, and just hope you make a full recovery quickly. And that was very, very interesting to hear from you about the work in Bangladesh. So thank you very much for that. We'll move on to the next presentation, and this time we're moving to partnership between Ireland and Kenya. So this is the Mayo University Hospital in Ireland, partnership with Londiani District Hospital in Kenya. And we're going to hear from the partners about the mutual learning and benefit between Ireland and Kenya to improve hospital and community health services. So I'd like to welcome the speakers, with Dr. Maeve Ní-Bhuineán, who's been a consultant obstetrician and gynecologist in Mayo University Hospital since 2001. And she's volunteered with Brighter Communities in Kenya since 2005 on rural maternal survival interventions at both community and health facility level. And with Brighter Communities and the management teams of Londiani Sub-County and Mayo University Hospital, she has led their partnership development since 2007. And I also welcome Anna Chelangotsoi, who's a registered nurse and midwife, and she's been the nursing officer in charge of Londiani Sub-County Hospital since 2004, in charge of mother and child health and family planning. And then in 2016, she became the assistant chief nursing officer in Kericho County until her retirement last year. And Anna has been involved in the Hospital Link project since its inception, and she came to Ireland in 2014 on an exchange visit to Mayo University Hospital. So I'll hand over to you, Maeve and Anna. I look forward to your presentation.
Okay, I'm Anna Soy. Thanks for the opportunity. I'm happy to report on the continuous development of our institutional health partnership. That is Londiani Sub-County Hospital, Mayo University Hospital, facilitated by Brighter Communities Worldwide. And more recently, on 2019, we were joined by our two university partners. That is Kenyatta University, Kenya, and NUA, Galway, Ireland. And our presentation is on improving health service quality through health partnerships. That is mutual learning and benefit through partnerships to improve hospital and community health services between Londiani Sub-County Hospital, Kericho, Kenya, Mayo University Hospital, Salter Group, Ireland, Brighter Communities Worldwide, that is a non-governmental organization, Kenyatta University, Nairobi, Kenya, and National University of Ireland, Galway, Ireland. Over to you, Maeve.
Thank you, Anna, and thank you, David, for the opportunity to present today. We're now in the third cycle of partnership, and we've been helped along the way by different guidelines so that mutuality and reciprocity were established from inception. We had a Schools Link programme guide to set our first value system on, and then the PET International Links guide, and more recently ESTER guidance and WHO partnership guidance. While our entry point was HIV, next slide please, and mother-to-child transmission, it was clear from the outset that one couldn't address a single programme in isolation. So we did commence with those systems thinking from the beginning. I think it's fair to say that every member of our partnership teams in both countries is motivated by quality improvement. And the inner workings of our particular partnership remain that we are nested in wider community development. So it's not the two institutions wishing to retain solely an institutional partnership, but to be part of a whole process of community development in both communities in rural west of Ireland and rural west of Kenya. We think we're a good match because we're both set in rural areas where government hospitals align with our national programs. We both provide secondary care, and we both have communities where primary care can be scant and patchy. We have island communities in Ireland and remoteness, and the communities in Londiani share the similar challenges of geographical remoteness. We're not afraid to evolve. We have changed our direction over the years from clinical service provision, in-service training, and exchanges to more focus on sustainable education methods. And the introduction of the university partners with the work of Yvonne Finn in Galway and her partner in Kenyatta University is to hopefully allow us to do some more operational research, which we've heard from the partners in Germany and with the German program this morning. So the big key activity here is that the Facility and Community Development NGO, Brighter Communities, keeps us in touch with each other more so than we could probably have capacity to do ourselves. It keeps us as a stakeholder. It provides us with a reporting structure. When I say us, I'm talking about both our institutions. And it brings charity governance to bear on the work that we do. challenges both of us as partners to be innovative in what we do. So I'll hand back to Anna for the specific learning outcomes that we have considered.
Okay, thank you. Thank you, Maeve. What we have learned as individuals. We had an exchange program which opened our minds. And through these exchange programs, we are able to obtain more skills. And at least we could walk around the facility so that at least we see what is happening in the facility. We are also able to, we had experience in managing new cases. That is, we had to learn new trends and ideas in medical field so that we get to know how to go about it. An example is an increase in non-communicable diseases, which is rampant. That is the hypertension and the diabetes. We also have as an individual, we have learned about the staff management. With the staff management, at least we need to interact with our staffs. We work easily so that we know their weaknesses and strengths and their emotions. And then from there, we can solve any problem which arises. There's also the personal relationship. In our personal relationships, we create rapport and network with people so that they can give us ideas, grievances, and solutions. We also need to give back to the society. By giving back to the society, we always need to be available so that we mentor them, we educate, we sensitize and assist on health matters, especially in this era of the COVID-19. We should also have self-management. In self-management, we need to be responsible. We should be accountable in all the tasks that we assign so that we can be relied on to deliver excellent services. Next, please. What we have learned as health workers. As health workers, we have learned about the capacity development of the staffs through sharing and learning experiences. And in the capacity development, we normally have what we call continuous medical examination sessions. These are held weekly in the hospital, and our staffs get updated. And if there is any staff who has gone for a seminar or a training, they come and give the feedback. This improves our competences and skills. Then there is the reciprocal learning. In this learning, we learn from each other. And also through the exchange visits, there was an exchange visit between the Londiani Sub-County Hospital and Mayo University Hospital, and a series of online workshops. This has really greatly assisted us. And we also learned the best practices. Like us, as a Londiani Sub-County Hospital, our best practices we learned from Ireland was about the neonatal resuscitation, trauma care, maternal and child health care, and even antenatal care tracking. And Ireland also learned from us about the kangaroo mother care and the COVID-19 and non-communicable diseases. So with the COVID-19 and non-communicable diseases, Ireland gave us a chance because they were affected first before us. So they had to train the staff so that we know what to do so as to prevent the COVID-19. Staff learnings as a team. Learning from best practices in Kenya. So the Ireland team learned from us about the tropical diseases, the resource management, integrated HIV, sexual health programming, nutrition and breastfeeding, kangaroo mother baby care. They also supported us in times of crisis, like during the economic crisis, political crisis, and especially this era of the COVID-19. Then we also established friendship, that is good relationship between the partners. And with this relationship, we build teamwork. So facility strengthening. With the facility strengthening, there was in antenatal care, we have had an increase in mothers completing 4 A&C visits. So this was successful through improved A&C tracker system and the community health volunteers. We have also had an increase in hospital deliveries and reduced home deliveries. And we have had stronger link with the community through the community health strategy. As by now, we have community units, and through the community health volunteers, the communities have been able to link the hospital for services. Still in facility strengthening, we are grateful to the brighter communities worldwide because they improved our infrastructure. Like they built for us a twin operating theater. They also purchased an ambulance for the hospital so that we could use it for referral. They built a maternal shelter where the mothers from far can come to the hospital and wait, especially those who have complications, so that at least they can have a safe delivery. And they did the renovations of the maternity. So over to you, Dr. May.
Thank you, Matron Anna. So as our cycle continues, we have worked on many educational courses together. We have included the global health attributes in our core curriculum. We have committed to low fidelity simulated methods on both campuses. The previous slide, please, thank you. We use train the trainer methods for sustainability, and we continually look at bi-directional, in fact, multi-directional activity of our learning methods. And we are sharing vertically and horizontally, both in Ireland and Kenya within our regions and spreading out throughout our counties. And next slide, please. From a systems point of view, we certainly see workforce capacity development. And of course, we might have started in the maternity service, but we've rolled over into the perioperative side. We were looking at trauma care, looking at safe transfers of patients. And from the south back to the north, the experience of the Kenyan link with the teams that have been from Mayo is to consider more ambulant care models for our setting, including in gynecology, moving cases out of theatre and bringing in some of the safe abortion care models that we have seen in the Kenyan situation, even though our laws are different and we respect and align with our own national status. From a quality improvement, which is key to this meeting today, we have again from south to north looked at greater engagements of the patients at management team level within the hospital. And now there's a regular chair of the patient forum who sits in the quality team within the hospital, which is new in the past 18 months. We have been able to strengthen our patient experience advisor program and our community engagement, often from what we have learned on the ground and with our Kenyan colleagues when we see the communities as stakeholders at the table in the Kenyan board system. We have used materials that we have co-developed in Kenya for community health workers, for nurses and clinical officers working alone in dispensaries, and for the district hospital. And we have used those same courses for primary care physician training in Ireland, and particularly the doctors that we receive in this part of the country tend to work in rural practice on peninsulas or where travel and access for quality services is a challenge. And so we've been able to use the same coursework for those in both maternal medicine, newborn care and trauma care. And of course, we bring many components to our teaching. In both institutions, we have colleges that we align with, and we teach and train healthcare workers across many domains. And what we learn together in our hospital systems allows us to improve our teaching. Next slide, please. I've mentioned community engagement, just to reinforce the point that the institutions alone are as good as the communities they serve. So without good access and acceptability to the community, without engagement and buy-in from the community, and without understanding the community delays models of the person needing to act first and to navigate the informal healthcare space, then our institution is not able to provide a safe and quality service. And I'll hand back to Anna now for our second last slide. Thank you.
Yeah, just to say our time is running out, so if you could be wrapping up quick soon.
Yes, thank you. Thank you, David.
Okay. COVID-19 preparedness and facility strengthening in Mayo University Hospital and Londiani Sub-County Hospital. We had capacity development of all healthcare workers in COVID-19 treatment and management. They also provided us with PPEs. There was the provision of hand washing facilities. There was provision of banners and posters. They also renovated the isolation wards, and we had shared workshops, guidelines, and experiences. And still we have similar experiences. So we have fears, anxieties, supply chain, quality care access, and assistance from Irish Aid Stroke Esther Island, and joint workshops and the new technology. So COVID-19 came with challenges, and one of our fears is how long will it last, as it has strained the healthcare system, resulting in many facilities and affected the economy negatively. Back to you, Meg.
So David, will wrap up now with this slide. And certainly this year, this has brought our challenge to think about new ways of work, to consider sustainability, and and globally, I think we are all reflecting on equitable access to quality services. For our partnership, we look at succession, as we don't wish to exit. We look at the positive enablers we've had over the years, and we consider how we grow. And continuously, we are in our cycle of quality improvement. Are we doing enough? Is it too soon? Is it too little? Is it too much? Is it too late? And these are the challenges for both settings in our day-to-day work as frontline workers. And thank you very much for the opportunity to present on behalf of Anna and myself. Thank you.
Thank you very much, Maeve and Anna. That's another very interesting presentation and just a lot of very interesting learning for the partnership on both sides, and we appreciate that. So we'll move on to our last speaker for today and our last partnership. And this is the Twinning Partnership for Improvement between Timor-Leste and Macau SAR in China. And we'll hear from their learning and experiences to ensure the sustainability and rollout of actions to the wider system. I'd like to welcome Melissa Klein-Bingham, who has been leading on the coordination for Twinning Partnership for Improvement between Macau SAR Health Bureau and Timor-Leste Cabinet of Quality Assurance and Health. And Melissa is also currently on the ground in Timor-Leste supporting the COVID-19 response. She specialises in improving health service quality through infection prevention and control and water sanitation and hygiene, and has been consulting with WHO since 2014. So thank you very much, Melissa, for joining us today, and I'll hand over to you now. Can't hear you. Are you muted?
I was, yeah. It's great to be with you. Thank you, David. Just to check, you can hear me okay now?
Yes, indeed. Perfectly. Thank you.
Okay, great. Well, I'll just try to take a few minutes. I know we're wrapping up, but I just first and foremost want to say a big thank you to David and to all of those who helped to organize this webinar. It's really great to be a part of it and really great to hear all of the various presenters on the work, on the really impressive work that's been going on. But what I want to do over the next 9 or 10 minutes is just share a few learnings from the Twinning Partnership for Improvements between Macau Special Administrative Region and then Timor-Leste Quality Cabinet. Next slide, please. So yeah, as I just said, share the TPI experience and then review some of the activities, but then also highlight some of the preliminary lessons that are learned. Next slide. So you've heard from my colleague, Dr. Syed, and I won't go into this, but just to highlight that this partnership that is currently ongoing in Timor-Leste and Macau is really, it's built on the quality improvement principles that are discussed here within the partnership preparation package. And just to reiterate what Shams has already mentioned, this partnership model works off of 3 objectives, noting the partnership, the improvement, and the spread as being those 3 objectives. And then it works on a systemic 6-step model in order to move forward throughout the partnership cycle. Next slide. So this partnership is between the national health authorities in Macau and Timor-Leste. And the model took a hub and spoke approach in order to really align the partnership principles with the national direction on quality. And as many of you probably already know, Timor-Leste is a fairly new country, really just within the last 20 years or so. claimed its own independence. And so it's really an impressive time to be here because it's starting to pave the way for some of its quality agenda. So this model really wanted to highlight that and really wanted to use that approach in order to create alignment in the different improvements at 3 different health facilities. So you'll see on the right side of the screen, HNGB is an acronym for the National Tertiary Hospital. POCUS Referral Hospital is a municipal referral hospital, and Riamara CHC is a community health center that's based in the POCUS municipality. And so these 3 health facilities are what we focused on as far as the actual improvements on the ground. Next slide. So, and then hit next, please. This is an animated slide, thank you. So just to highlight some of the steps that have been taken. So in May, there was an inception meeting in Macau, where all the partners joined to just agree that the formal partnership was going to take place. In November, as part of meeting the step 2 is a needs assessment, an on-the-ground needs assessment. And this was prefaced by a rapid desk review on the policy and strategies that had already been set forth in Timor to really understand the lay of the land and what had already been developed. And then of course, the in-country assessment really focused in on understanding where the gaps and strengths in Timor-Leste are. And then in March, just a few months later, a gap analysis of that situational analysis was done to further expose what improvement areas could be worked on. Next, please. So then the partners came back together in April of 2019. And within TPI, there's a very strong emphasis on co-development. So everything that the partners do really should be decided upon in tandem. So in this case, there were 2 priority project areas. One, which we called PP1, was really to help support the national direction on quality. And then the second one was to support the health facility improvements on infection prevention and control. Next, please. And then lastly, just to note that step 5, the action, has been ongoing for a little over the past year. Next slide. And then just quickly to highlight that any partnership the TPI model supports, we really advocate for some co-developed and agreed upon principles or values that can be carried forward in the entirety of the 2-year partnership. So just to highlight as an example, this is what Macau and Timor-Leste had used to define the ways of working throughout the course of the 2 years. Next slide. So coming together right before action, right before step 5, the partners came back together on the first partner exchange visit. And this had been done after they decided to focus in on infection prevention and control as the priority improvement area. The partners decided on 4 chief objectives in order to start improving IPC. So one was the development of the IPC team. The second one focused in on training, and that was really around the 8 standard precautions of infection prevention and control. The third objective is on facility materials. So that meant really supporting with either the refurbishment or new materials needed in order to support WASH infrastructure, which is so critical in order to have people adhere to good IPC practice. And then the fourth objective was a emphasis and on hand hygiene. Next slide. So just quickly, I want to talk about some of the achievements that have been made from those 4 objectives that had been agreed upon about a year ago. So the terms, in order to build the IPC teams, terms of references were defined between the 2 partnerships. And currently the teams are actively building their capacity to have IPC teams in those 3 facilities. And then during the first partner exchange visit, which was part of step 5, Macau colleagues and Timor colleagues, they did joint training sessions on infection prevention and control. So areas of waste management, sharps prevention, as you can see in the picture, personal protective equipment, so on and so forth. Next slide. They also did capacity building workshops, and this particular picture was around capacity building workshop on IPC assessment tools and audit tools. Next slide. Next slide. Thank you. So then just to highlight some of the infrastructure improvements, this was a before picture. And then if you go to the next slide, there's an after picture of some of the improvements that had been done. Next slide. Water, as she goes to the next.
Sorry, Minister, just to be finishing up shortly, if you could, please. Thank you.
Sure, yeah. And just to highlight as well, one of the big lessons learned is that campaigns can really do a lot as far as fulfilling that third objective of spread. And so this was just to mention that the hand hygiene campaign, so there's a WHO May 5th hand hygiene campaign, and we were able to take advantage of that and utilize that as a way to really reach out throughout the country and really help support the education and advocacy around hand hygiene, particularly in the time of COVID. And so this also allowed us to utilize the WHO hand hygiene self-assessment, so we could collect data and understand a little bit more about the systems issues around hand hygiene throughout the country of Timor-Leste. So not to emphasize the data at the moment, but just to highlight that that was an opportunity which was a bit serendipitous. We hadn't planned for that to start, but provided the national authorities with some good grounded data on hand hygienes and system level thinking around that. Next slide. So since we're short on time, maybe I'll just stop at this slide. And just to recognize that the IPC, these are preliminary reflections from some of the participants on the IPC strengths and gaps following the activities that had been set out in Timor-Leste. So they really felt the twinning partnership on both sides really helped to improve the leadership, both in Macau and Timor-Leste. More specifically on Timor-Leste's side, the multimodal strategies, which really is more of a reflection of creating a culture of safety within health facilities, behavior change as well. And of course, the built infrastructure. This was really the first time facilities had an opportunity for any kind of resources to support them in building that infrastructure. And then, of course, improving the IPC programs. And Macau colleagues also felt that their programs were able to be expanded because of the learning and the teaching that they got to do through this partnership. And then a reflection on how staffing had been better delegated to where people could actually prioritize some of their time on working with IPC. And then if there was any silver lining with COVID-19, I think throughout this partnership, it was that it did provide opportunities to scale up the training around IPC, and there was actually a big asset in being able to utilize the resources from the partnership to help the country to do that. So maybe at that, David, I know we're short on time and we're coming to an end, so I'll stop there and I'll hand it back to you. Thank you.
Great, no, thanks very much. So that's very interesting. And again, sorry, I know you could have liked more time, but we do only have about 10 minutes left. And I'd like to invite all of the speakers from the beginning, if they could have put their cameras back on and perhaps leave them on until the end of the meeting. We only have about another 10 minutes left. Now, in terms of questions, there's not so much been coming into the Q&A, but there's one question, and it's also been a similar comment was made, and I might put that to all of you. And it's really about from people who are wondering how you identify your partners at the beginning. So we've heard a lot about successful partnerships for improving quality. We've heard things about the steps, how you develop that relationship with the partners. But what about if you're in an institution, it could be in a higher income country or a lower income country, and you'd like to find a partner to work together with? And maybe maybe anybody got some advice for those people of where do you go? What do you do? You've all done it. Anyone like to have a go at that? Maeve, I see you're looking in there.
Just to avoid silence, I'm happy to say that often it's serendipitous that we might know somebody in another institution. But just interestingly, because last year we had the experience of 2 university partners joining, Margaret Karaka from Nairobi and Yvonne Finn in Galway as the leads there. That was a cold call, just an expression of interest. If I were starting all over again now that we've a national global health programme, that's where I would begin. I'd go to our national global leads and see, is there, a partner arrangement? And of course, I'd take out Sham's handbook and look at the structure from the beginning. So that came 10 years later for us, but we're still studying that handbook.
Yeah, Shams and then Laura.
Yeah, David, it's a great question, and it's a difficult one. Just to highlight that, I think just building on Niamh's point, I think the power of human interaction cannot be overemphasized. So actually having that linkage with a person and bridging countries is important. And I think it is really good to see that there are a number of partnership-focused organizations across the world now. Of course, Esther's work, and then we have SET in the UK that's been mentioned a number of times, and a number of other partnership-focused organizations that are actually often looking for tangible, real, people-based partnerships that can take forward a specific area of work. So just to emphasize that, I think that human interaction and finding the person to link up with and building on some already existing arrangements can be a reasonably good way forward. Not totally satisfactory as an answer, but a start.
Thanks, Shams. I think, Laura, you wanted to come in?
Thanks. Yeah, so I think one of the things that we really like with our 4 partnerships is that that we have a large diaspora community in South London from the countries that we work with, and there's great opportunity there for mutual benefit and learning for our work in the NHS. I've certainly hugely benefited personally from having a greater awareness of the culture of Sierra Leone in my work, and I've got some practical examples of how I've then put that into practice in South London, and now I'm not alone in that. How it all started, I mean, long before I was involved, but as I understand it, was our director of the Centre for Global Health at KCL, Andy Leather. He met some people from the Somali community in South London, and they invited him to travel to Somaliland, and that's how the partnership originally started there. I think one of our really important principles is that we only work by invitation, and so all of our other partnerships have developed from an invitation from people in those particular countries. And as many others have said today, that principle of working through mutuality in areas of common interest is really central to our work as well. So I think that's how it all started for us.
Great, thanks. Anyone else want to come in on that one? Okay, I have to just check if there's any other, we've covered the questions. There's a question about how the speakers dealt with the informal systems that are often in existence in partner countries. Very often informal systems that generate small payments for certain, usually low-paid individuals in health facilities stand in the way of changes and streamlining of treatments. How have you dealt with this? That's a tricky one. Anyone have a comment on that one? Don't see anyone out with any answers. I don't see any other burning questions.
David, would Anna maybe talk about the Lundiani experience, because that's very much volunteer led?
Yeah. I don't see if she's. Oh, Anna, you're there. Yes, Anna, would you like to come in there?
Okay, with the informal system in the hospital, I feel it doesn't work, because with the informal system, you cannot reach everybody. So I feel we should use a formal system, because in the formal system, at least you have given and you have communicated to somebody. That's what I can say.
Yeah, thanks. I'm just seeing another question coming in relation to what I asked before, and it was about how institutions or clinics in low and middle income countries can initiate partnerships. So we've heard kind of a perspective from some of our experiences in the higher income countries. But what if you're in a lower income setting and you'd like to find a partner in another country, a higher income country, perhaps? How might you do that? Anybody got that experience?
Can I talk on the part of Malawi?
Yes.
So for this particular project, as most people have said, it was just serendipitous that we met and then we started this. But I think if we had a new idea, would probably go through our college and find out if they're already interested partners that are interested in particular themes that we want to carry on with that partner. So you'd have to start from scratch and find out if there's anyone that's interested in that field amongst the partners, and then take it up from there.
Yes, thank you, Tamara. That's very helpful. So I think that we're just in the last few minutes, and maybe we don't have time for a final comment from everyone, but I would like just go back to Shams very briefly. Shams is our keynote speaker. If you just have any final brief reflection or on key learning today that you'd like to just leave us with.
Yeah, thanks very much, David. And really, it's been a fascinating 2 hours. It's gone by so quickly, and I know it's been quite hard to pack in all the wisdom. But there's just so much here to unpack. But if there's one thing that emerges from each of the presentations, just highlight one key point, which is probably not necessarily central to a presentation. But Dr. Kirsten, when you were mentioning the gender analysis of the workers that were trained, that really is an interesting lens, I think, which we could all apply. It's a hugely important area, but we don't always look at. But the 56% of the 1843 were women, and that's a really important point. And that's a type of thing that comes from a partnership when there's clear and effective analysis. In the Malawi Hamburg piece, I really thought that the spread within the institution was a very interesting piece. How does that happen? And really unpacking that spread is not just about facility to the national system, but even within an institution, there's always a core of improvement. There's a core of culture change that can actually cascade. So that was another very powerful point. In the King's experience, I really was drawn very much to these 4 interdependent areas as being cross partnership, and actually that learning that can occur between partnerships, even within an institution like King's, is powerful, and really focusing in on the management side, but in placing the QI piece very clearly within that was quite impressive. So a huge applause to our colleague from Bangladesh for being on the call in the midst of recovery, but the focus on social justice that Ganashastra Kandro has, and the focus on the WASH infection prevention and control piece as a clear entry point to that point was something that was really inspiring. And then thinking about the island Kenya piece, the fact that matron is there. I think there was a comment about whether the nurses are involved in partnerships, or nurses actually do most of the work in partnerships. So I think that's another really important point, to bring that nursing perspective into the entire partnership work, which is fundamental and key to the partnership. And then finally, coming to the experience in Timor-Leste, just reminding ourselves that there is this opportunity to partner national authorities that are working with a hub and spoke model that takes it all the way to the facility level. Again, so much more at this point in time. I'll pause there, and it's just been an inspiring couple of hours. And thank you again, David and the team, for putting this on.
Well, thank you very much, Charles. You put that so nicely in capturing those points. I don't feel I need to add anything more. I mean, I think we've had such a rich array of experiences shared, and I think like there's so much to learn in so many different things. I wouldn't even try and sum it up. And so I'm just really going to draw things to a close. And just could I ask all of you speakers, if you could just put on your webcam, we'd like to get a kind of a photo of the screen just of the event. That'd be very nice. Thank you. I'd like to thank all of our speakers today. I think we just had very, very rich experiences from all aspects of the partnership. So to thank you, and thank our partnerships, and thank our co-organizers. That's the Twinning Partnerships for Improvement Initiative of WHO, TESH Partnerships for Global Health, Esther Germany, Esther Switzerland, Esther Ireland, and the Esther Alliance for Global Health Partnerships. I would like if you could help us by completing filling the evaluation form that's been sent to the chat box. The recording will be available on our website, the Esther website, esther.eu, and on the YouTube channel, the Esther Alliance YouTube channel. So we will be having future events, so do stay tuned to the Esther Alliance, and we'll announce things on our website and on our newsletter. And there are questions coming up about how do we learn about partnerships. So I think a lot of learning today. We're going to continue learning. And I think through connecting with our different organizations involved in partnerships, like Twinning Partnerships for Improvement, the Esther Alliance and TESH and others, I think this is a way for us to continue our learning together. So thank you very much, everyone, to the speakers, to our participants. I hope you found it useful, and I'd just like to finish up by wishing you all a good day for the rest of the day. So thank you, everyone.
Thank you.
Thank you.
Bye.
And thank you for the moderation, David.
Thank you. Bye.
Bye.